Thank you. This work is funded by the National Institute on Aging and the Pennsylvania State Department of Health. The long-term goal, one of them, way down the road, might be to determine how social and structural determinants of health, including identity-informed experiences and lifelong exposures, modify associations between Alzheimer's disease molecular markers, neurodegeneration, and cognition. We're also working towards some of the goals that were laid out in the earlier part of this session today, as there's these tremendous efforts that are underway to bring racialized minorities, sexual and gender minorities into research. We have to start to change our practices, our centers, in order to welcome a wider range of diverse experiences. And so part of what we're here is the inside out, right, of how we change some of those processes. As Megan already introduced, social and structural determinants of health are the conditions in which we live. There's a wide range of experiences, opportunities, and challenges that vary person to person. These factors are important in determining an individual's health and well-being at points across the lifespan and cumulatively. These aren't new ideas, but there is growing recognition that social and structural determinants of health data can help explain health and healthcare disparities. We know, or you may be familiar from being in this field long enough, we know social isolation increases the risk of dementia. We know higher educational attainment it correlates with brain health and cognitive reserve. We know consistent access to healthcare services falls in line with better preventative health steps and early diagnosis, including for dementia. We know these things. So if we expand what it is that we're measuring, and we open up the way in which we're analyzing those data in our studies, what new discoveries can we make? My colleagues, many of which are in this room and on the agenda, laid out a roadmap with ADRCs in mind. This framework relies heavily on Brofenbrenner's ecological model, or what I'd like to refer to as the Crystal Glover model, that that there are 3 levels of environmental influence that impact an individual's development. Fundamental cause theory, which poses that what Megan had talked to, those social inequities and social resources are drivers of population health inequities. This framework also relies on the National Institutes of Health Disparities framework, as it adds to these 2 other models by putting a focus on intervention. So not only what is it that we can learn about the drivers of these disparities or differences in ADRD outcomes, but where might our intervention points be? So when we went into this, we looked to some of the measures that I'm posing here, build upon what Megan already talked about as going into the UDS new module, and some of them expand beyond that. We put these measures together based on discussions with colleagues at other ADRCs. We looked at the psychometric properties of available measures, and we tried to incorporate scales that were already in use, at least in some ADRCs. And we landed on 7 key domains, listed here on the right: social stressors and perceived stress, social support, education and health literacy, occupational, social positioning, social built environment, and social identity. Let's dive in on one of those questions. You saw this earlier in Megan's presentation. This is the MacArthur scale. It's reasonable to assume that access to resources, objective resources, could impact the opportunities that we can obtain and our health outcomes. There's also research that suggests that our subjective experience of our socioeconomic positioning can impact our health outcomes. That is, research has shown individuals who grow up maybe middle economic status, in a family of middle economic status, but surrounded by upper economic status households, fare worse than individuals who might grow up in a lower SES household surrounded by other lower SES households in terms of some outcomes. So the MacArthur question helps to address this by asking, where would you place yourself on this ladder from a scale of 1 to 10, with 10 being better, as compared to other peers in the US population. All right. Back over, I'm not going to go through all of these domains exactly, but I will just draw your attention to a few things. In terms of demographics, we built out our questionnaire from the UDS A1 form. So we started with some of those questions that were already there, and we added in additional items, including childhood background, languages spoken, and that we added the SOGI items, sexual orientation, gender identity, and rephrased the sex question. We include childhood adversity, discrimination, early education, health literacy, neighborhood characteristics. These domains are comprised of single items as well as scales. And then we set this up to include 2 forms. We do a full baseline assessment that's about 30 minutes to administer. And then we remove those questions that are unlikely to vary from time point to time point to reduce the length and get us to a follow-up questionnaire that we administer annually. So let's talk about a little bit about how we make the collection happen in our EDRC. This is set up in REDCap, and we have a research coordinator email the link out to participants shortly after they complete their annual visit. We have research coordinators that are available to help participants complete the survey. They can do it by phone, video, or in person. For those people who opt to do it in person, the default is on a tablet. But if they want, there's paper and pencil available, and then a research coordinator enters it after the fact. So let's move in. We put this out, we piloted it, and what we found was we sent it out to about 212 people, and we had 142 respond. So response rate of 67%, which overall generally for these type of survey, online based surveys is not bad. For the ADRC population, it might be a little low. Out of those 142, 135 completed the survey. And when I say complete, they did at least 1 question. They signaled that they were there, they pushed a button. Okay? And that gives us a completion rate of 95%. When we look at the non-responders compared to those individuals, the 135 that completed the survey, we see that there are slight differences in age and race between completers and non-responders. Really small differences, we're not quite sure, but we're watching it to see what happens as this survey continues to be fielded, and we start to distribute the survey to individuals with mild cognitive impairment. All of these individuals are cognitively unimpaired. So we went in and we looked at skip patterns, and we found that for skip patterns and completion rates, we found for the most part that completion rates for all of the items ranged from 83% to 100%. So most of the time, people were completing most of the items. The 5 most frequently skipped items are shown here on the right. And there's a couple things that stand out from those top 5 items. Surprisingly, we were surprised to see that they don't really include some of the items that we would consider to be sensitive, those around economics, those that people are concerned around sexual orientation. They're not there. The other thing, as we drilled down to look at why people might have been skipping those questions, we started to see that it may have not been content as much as issues with the structure of those questions. Another way of looking at this is where we looked at patterns of skipping across those 5 items and in the entire sample. Each one of these ovals represents one of those 5 questions, and we're just laying them over top of each other, so the numbers represent the number of people who skipped that selection of items. And as you can see, there's nothing that really jumps out, right? A certain pattern of people that they were just items that were being skipped here and there. All right, so we did want to go and show a slide specifically around sex, sexual orientation, and gender identity questions, just because there's been so much concern about implementing those questions. For those with eidetic memory, these items are slightly different than the ones that Dr. Flatt presented on earlier this morning, and that's simply because the work that Megan's doing, Jason's doing, myself, we're all doing it contemporaneously, and there's been versions that have been rolling out. These are the distributions, and overall we see a completion rate for these items of about 94%. So not bad, I didn't see quite the alarm or concern. 127 people out of 135 completed them, with distributions, I suppose, similar to what people would be expecting. All right. At the end of our survey, we included participant feedback questionnaires that had to do with the length, the number of questions, the content of those questions. And briefly here, I focus on just where the issues could be coming out of. We had a few participants, 5 out of those 135, report emotional discomfort or dislike with some of the questions. 3 cited specifically that they didn't like the questions about childhood because they caused discomfort. We followed up with those individuals, and while they acknowledged that the questions caused discomfort, they also reiterated that they were fine completing the questions. We also went back and edited questions based on the feedback that we got from participants. Some of this included, we had issues, we're doing a zip code recall, so we can match up with some of the GIS data and do geocoding, and asking people to recall the zip code and the time frame they're living in certain areas. And our initial run at creating those questions was a little messy. Their feedback helped us revise those items. We added schooling questions based on participant feedback because we found some people could not indicate their pathway through school with the basic questions that we were asking. And we got feedback from participants that they wanted more questions that were around risk reduction, hobbies and activities, and pleasantries that they enjoy, rather than just always being focused on the negative. So conclusions here. Overall, the implementation of the multi-domain battery of social and structural determinants of health measures in the UPenn ADRC cohort was feasible. We did it. The items had high completion rates overall, with a few questions that were consistently skipped by participants. While investigators seemed to worry a lot about offending, upsetting, or creating questions that are off-putting, we weren't really seeing that come back in the data from our piloting. Participants seemed more than willing to complete the questions and engage in improving the survey and helping us to get a clear picture of their experiences. Over on the right is a QR code, if you're interested, to the REDCap survey and the materials that we've generated so far. I would like to thank Dawn Mechanic-Hamilton, who's my partner in all this work at UPenn, as well as our colleagues at the University of Pennsylvania ADRC, and our collaborators at Rush, the Knight ADRC, and Wisconsin, and of course the iStart for the opportunities they've provided through the Diversity and Disparities PIA. Thank you.